So if you look at that, this statistics, this is actually a little bit old, 2014, but I think the trend is still the same. So the cause of death in major injury is actually very high. So other injuries, fire-related injury, fall, poisonings. So now, if you look at the statistics in Myanmar and current situation, maybe higher than this statistics. So because of this, why we have to emphasize the injury. So cause of death injury is, I think, around that all over the world currently. So this is the reason why we have to emphasize to the junior MO and also husband, house officers, why we need to emphasize the importance of the major injury. So there will be some practical reason in Myanmar also currently, right? So this is the severity of the injuries. Depends on the nature of the injury. Depends on the nature. So because of this, cause of death is the highest, one of the highest, and the injury is the one of the highest cause of death in the list. Okay, so this is the most important slide. Some of you have already seen. Maybe some of the postgraduate here, you are very familiar with this. Some of the MO or HO who currently working in the orthopedics work or A&E or trauma work, they also have a experience of this trimodal pattern. Some of you might not know yet. So this concept is the most important concept of the two-day lectures. So immediately after injury, there are possibility of the death in 3 occasions. So one is that immediately after injury. Immediately after injury, first peak, we call the first peak here. So this first peak is first peak. We cannot do most of the orthopedic surgeons or trauma surgeons, we cannot do anything. So in a very death, direct crush in brain injury, transection of the spinal cord, open heart injury like this. So no one can save, even the God cannot save. So the most important thing is the second peak, this second peak. So now today we are going to discuss is this second peak. So if there is a proper primary trauma care, we can save the life in the second peak. There is another cause of death in the third peak after 2 weeks, 3 weeks. So this is the hospital care management. This is the problem in hospital care management. This is the primary care management. So this second peak is there, depends on our hands. It depends our management's primary trauma. This depends on the hospital management. So in Western country, nowadays, the newer trend is they emphasize only the first peak and second peak. Even they don't mention about the third peak. Because nowadays, hospital care is a very good quality hospital care. Mortality rate is very low, even there is no peak anymore. So, but in Myanmar, a country like Myanmar, we can still have to think of the possibility in after 1 week, 2 weeks, 3 weeks. And they are, even I saw in the news and current situation, there are some of the patients, they lost patient after 1 week, 2 weeks because of the failure of the hospital management. So, but most of the death is here because of the primary trauma care, failure of the primary trauma. So within 1 hour, 2 hours, you can control the patient's situation. You can save a lot. Let's see now, I saw around about 800, right? 800 casualty during current situation. So if we have the proper primary trauma care, we may reduce that to 400 or 300 lives. So most of the death, because of that, we cannot control the situation within this 1 hour, 2 hours. So this, but then what is there critical to understand the management of major injury. So today, what I want you to understand is this one. After that, now if you want to sleep, you can start to sleep. Just joking. So right. So And what I want you to understand is that this first 2 hours is called golden hour. If you know how to manage the patients properly, 1 hour, 2 hour, you can save a lot of life in emergency situation. This immediately after injury, don't worry. If you lost the patients, don't worry immediately after, no one can save. If you lost 1 hour, 2 hour, 3 hour like this is because of our poor management. So this is the thing I want to emphasize today. So today I'm going to discuss what way we do in this 1 hour, 2 hour, how we can reduce the cost of death in this 1 hour, 2 hour. So forget about that big awesome hospital after hospitalization. This is beyond our hand, beyond the scope of the discussion also. So we will focus only this 2 hour. Golden, we call that trauma care, we call that golden hour. So we will discuss about this. So this is the, just now I explained in the first slide. Initial mortality is usually non-survivable. So who can save? So that be also because of the multi-system failure, something like sepsis, septicemia. This one also actually because of the poor management in hospital. All right. So now, what is the cause of death here? You look at hypoxia and hypovolemic shock. These two situations, yes, if we can control the situation properly, we can save the life of the body. So because of this, you must have the idea is, if you see the patient, trauma patient, maybe in roadside injury or gunshot injury, or if you are in emergency department. So if it is within 1 hour, 2 hours, you must have the idea. So I have to correct that these two situations immediate cause of death. Yeah? So is there any patient is with hypoxia or patient is with hypovolemic shock? So if you can control that this situation, you might be able to save this patient. Yeah? So this, because of this, we call this golden hour. We call this golden hour. So this is the concept I want to give you. Some of you who do not familiar with this concept. So after this lecture, you might have the familiar with the golden day, golden hour. Okay, the second big 1 hour, 2 hour is in my hand. Right. So if you have the idea like this, right, you will try to save the patient life. You will try to save the patient like this. Okay, so let's see what is the problem. So this is the proper sequence here. Dashboard picture. Proper sequence in dashboard pictures, but in practical, we cannot follow exactly like this if you do not have the proper training. If you do not have the proper training, so I will not go in detail step by step this. So it is not about to blame of you. I will share my experience. We ourselves are trauma surgeons. So we are together with our boss, very famous trauma surgeon now, right? So that time is 2008, I think. H2O Bomb Blast in one of the New Year the Gem Festival Bomb Blast in Yangon. H2O Bomb Blast. More than 100 patients came to the Yangon emergency department. I was on duty that time. So we ourselves, the trauma surgeon, we train student, medical student, nurse, right? This pre-hospital management. But if the patient really came in the resistance, we also became disorganized. So we do not know from where to start. We do not know from which patient to start to treat. 100 patients came to the emergency department at the same time. So you can imagine how disaster is this. So this is the H2O bomb blast. Before this is the 2007 several revolutions. So at that time, I was also in emergency department. I have treated so many cancer in there, including the one who passed away, Japanese reporter. So, so theory is theory, but if you do not have the proper drilling, sometimes it becomes disorganized. Sometimes the management will become disorganized. So because of this, I recommend you, after you understand the theory, try to prepare yourself to be ready. So try to prepare yourself, try to prepare your mind. Try to prepare. You just know the theory, and if you do not prepare your mind, uh, you will not be ready. Your psychomotor is not ready together with your mind. So I want to share one another example. This one is around about 25 years ago. I was in medical student life. So I visited Donggu because at that time I remember it's during the 1997 or around like this. So while I was in the hotel, I was in the hotel lobby. So there was a step-one patient in front of the hotel. There was a step-one patient in front of the hotel, and then as you share our Myanmar time, so all the people around the hotel are looking at him, and then we do not know what to do. We don't know where to step. And I myself, also medical student, I do not know what to do. But there was a hotel case from the Western country. Actually, she is from Switzerland. So, so she immediately rushed back to her room and then brought back the first aid kit. And then tried to see the one. She is landscape technology engineer. I still remember we became friends. Landscape technology engineer. And then she tried to seal the wound immediately and then sent to the patient to hospital. So she is a landscape technology engineer and medical student. I was the medical student. I feel really embarrassed. So what is the difference is that the way we train ourselves, is the response to trauma. Our tradition is just see, look around, and then we do not know what to do, and then chit-chat each other, right? So we are just contemplating the sense of the crime, not try to save the patients. This is what I really experienced, and I took the lesson from it. So we have to just not because of the knowledge, we have to train ourselves to respond appropriately. So because of this, especially in this type of situation, it is really need for you to prepare your mind to respond immediately. So this is the really good example how they train themselves and how we train ourselves. So medical student do not know what to do, and then engineering student. So she saved the patient life with the emergency kit. So this is the theme, right? I want to emphasize that now there is the pre-hospital management, step-by-step, organization, safety, immediate action and triage, so assessment and initial management. So if it really happen then, right, sometimes you get to go step-by-step. So based on the current situation, I'm not going to emphasize detail about the organization and safety of the same. I will start with the immediate actions and triage, and then assessment of the initial management, mainly 3 and 4. Extrications and immobilization, transport to hospital, helicopter, and ambulance. I'm not going to go. This is beyond our current situation, right? About our current situation. So it is more practical for you if I discuss more on the 3 and 4. So I will emphasize more on 3 and 4. But one thing I want to point out is number 2, safety, especially. So just want to remind you, if especially in current situation, so please be aware of that. If you are in the safe place or not before you save the other people, right? So this is practically important for you. particularly important for you. So before you try to save the other people's life, be aware of the surrounding, the environment. It is really safe place for you to do resuscitations or to keep the treatment. Okay, you will understand this. Okay, so I start with the immediate actions and triage. Immediate actions and triage. So triage is actually transport. We try to sort it out there. Different type of patients. So like just now I said, I gave you the example doing H2O bone blast. So doing H2O bone blast, more than 100 patients can. So we do not know from where we have to start. So just patient with the abrasion also shouting, just patient with the open chest injury also shouting, right? So we do not know which patient to start. So because of this, there is a ATLS, we call the ATLS protocol. ATLS protocol. So just for your general knowledge, the ATLS is started developed by the American surgeons. He's an American surgeon. He lost American orthopedic surgeon actually. He lost his wife and children during the plane crash. During the plane crash in the 1976. So that time there is no proper trauma protocol in US also. So what he realizes that if we can develop the proper trauma care management, we can save a lot of life. Like just now, I explained in the golden hour, right? So because of this, he tried to develop the ADLS protocol and then try to develop this triage system. So if we can categorize the patients properly and then we try to save the patient, those who need the immediate care, we can save them a lot of life. So because of this, what we have to do is we have to do quick survey and quick assessment. Then we have to prioritize the patients in the different color. So if you do not have the proper triage, you can even use the ribbon or you can use your marker, right? Marker pen, put the marker pen in your pocket and then you can write on the patient's forearm what is this category, right? In emergency situation. So quick surveys and then you can categorize. After that, then you can decide what kind of patient I need to give the immediate attention. Then after that, I'm going to explain how we categorize, but it takes around 1 hour, right? So this lecture will take around 1 hour. But in practical, you have to decide within minutes. We have to decide within minutes which patient is red color, which patient is yellow color, which patient is black color, right? Black color is easy to categorize. So first, before you resuscitate the patient, first you have to check is that whether the patient is priority 4 or not. Don't waste your time in patient with the priority 4. But you might have a feeling, right? So you want to save the patient life. Maybe the patients will be your close friend. Right? So, but we have to accept the reality. Your patient is in category 4. Don't try to waste the patient with this category, right? Let it go. So you have to save the other service patients. So first, before you start to do this action or we start to do the primary survey, the first step you have to do is whether your patient is alive or not. If your patient is not alive, this is category 4, tag in black color or write on the forearm black. If you have the ribbon or you can tie on the hand. So first, second is right, who can be delayed. So you check the vital signs and then check the quick surveys head to toe. The patient with the minor fractures, there is no vital injury, you can delay the treatment. Right? Patient might be there shouting, patient may be anxious, right? But as a medical doctor, as a medic, you categorize this is delay. Also, you should not waste your time in this kind of patient. So what I'm telling is that in case of the SESTA, like just now I explained you the H2O boneless, H2O boneless. So in the SESTA, if you are patient, you have only one patient or two patients, that is okay. You want to attend the priority 3, you want to keep the time priority, also no problem. But if the patient is more than beyond your manageable, remember, right? You are the only MO or only medics. Patient is more than 10 or 20, right? So in this situation, yes, you have to categorize which one is a priority 3, which one can be delayed. You write green or put the green tag. So priority 2 and priority 1 is our focus. Priority 2 and priority 2 is our focus. Even priority 2 is urgent, but you can still delay a few minutes. Priority 1 immediate is you cannot delay more than 5 to 10 minutes or you will lose patience. So this kind of patient you have to take immediate actions. This kind of patient you have to take the patient. So if you see the patient, check whether patient is alive or not. Second, check whether patient is can be delayed or not. Then after that, decide what action you have to do, priority 1 and priority 2, then take the action. This is generally what we do with the emergency department of field management. So to understand which one is priority 1, 2, 3, 4, right? To triage. So what you have to do is assessment and initiation. You have to assess the patients. You have to assess the patient. So awareness of the environment and pattern of damage. Then you have to go ABCD or trauma assessment. Most of the medical students and most of the MO, they understand very well what is ABCD, right? So, but practical. So what you have to do is sometimes you might not familiar with. So in theory, you will know the ABC. So first awareness is what I want to see. So awareness of the nature of injury. Awareness of nature of injury. So the scene of the accident is the bone bloods. Gunshot. You should have the high awareness of the possibility for red color and yellow color. So the scene of accident is something like that. Just assault, minor assault, right? In this case, most likely to be the green, right? Most likely to be. This is what they want to say awareness of the pattern of damage is also maybe fall from height. I hope you guys had someone jump from the building, right, to try to escape from the arrest. So fall from height. So you have to understand is that if it is more than 20 feet high, it is a major injury, possibility of life-threatening injury. So just to say the joke, if you guys want to escape or run away, if you are supposed to jump from the building, if it is more than 20 feet, you guys don't jump. All right. So if less than 20 feet, if you want to try your luck, you can still jump. But don't jump more than 20 feet. 20 feet is a life possibility of life-threatening injury. So I'm just joking. Don't take it seriously, right? So just to remember, 20 feet high is a possibility of a high impact injury. High impact injury. Okay, so after that, you have to do assessment. You have to do the assessment. So first, what you have to do is an airway spike as well. So initially during our student life, this is only airway management. Nowadays, they add the airway spike as well because if you are going to correct the airway, if you are going to treat the airway, what happens is you have to manipulate that, you have to hold the spike spine. If your patient spike spine is not stable, what happens is that because of your management, you will break the spike spine or you will block the airway again. So because of this, you have to correct the airway, but at the same time, you have to give special attention to your spike spine, not to move the spike spine. This is also very important. So you try to talk the patient. You try to talk the patient. If the patient can answer your questions, generally you can assess. Like this is the airway is clear. Patient airway is clear. If you have the stethoscope, so listen the air entry. Listen the air entry to the chest. Listen the air entry. So if there is obstruction, so you will see, right, some abnormal sound. You will hear some abnormal sound. So what are the possibility of airway obstruction? So in trauma, facial injury, bleeding inside the mouth. Sometimes patient O2, sometimes foreign body, sometimes fracture of the mandible nose. So in this situation, airway can block. In this situation, airway can block. Sometimes foreign body inside the mouth. So sometimes you need to wipe out the mouth to remove the foreign body. If there is airway obstruction, you have to open the airway immediately. At the same time, you have to control the spike, especially patient with the facial bleeding, patient is with a supine position, or the blood will drain back to the mouth pharynx. So in this case, you might need to turn the patient side. Then you might need to open the airway, look at the patient mouth, any blood clot bleeding inside, or any foreign body inside. So first step is that you can, without any device, you can try to open the airway. Any blockage in the airway, then you can see that any foreign body inside the airway, then you need to try to remove the obstruction first. So this is the one of the method of the airway, treating the airway obstructions. Very simple. You just lift the chin in this position. So most of the airway obstruction case, you put your hand in this position, and maybe you can ask your assistant or one of your friends to listen there, to listen the air entry. So if there is a normal entry again, then okay, you can put that patient maintain this position for a while. So this is the jaw thrust. So sometimes you might need to lift at the jaw in this position. So make sure you don't twist or you don't move the spike spine. You don't twist the spike spine in this position while the patient can open the airways. So this is the fastest way and easiest method to open the airway. After that, if you have the cervical collar, put the cervical collar. Sometimes in practical, in the field, in the roadside, you might not have the this spiker collar, right? So you might not always ready the spiker collar, but we recommend that during our medical student life, any have object you can use as a spiker spring. So we recommend a small pillow and take around the forehead, or maybe I remember one of our professors said even you can use the brick. In Myanmar, there are a lot of bricks on the roadside, right? So put one brick, one on each side of the cervical spine. Then you tape around. So this is not the proper way, right? But at least what I want to say is that you should have the idea to immobilize the airway is important. To immobilize the cervical spine is important. So later, if you're going to train the HCs or nurse or some medical junior medical students, what you have to do is immobilize the cervical spine in any case. This is important. This is important. So because and they prove otherwise, before you get the confirmation from the X-ray and complete physical examination, all the trauma patient you should treat as a cervical spine injury patients. This is the reference line. So because of this, if you do not have the proper cervical column, so you can use any hard object around you and put around as a spring, as a spiker collar. This is a recommendations in primary trauma care, primary trauma. So because of this, I recommend you try to use any hard object around you, put one on each side of the spiker spine and then wrap with the bandage or close, whatever. So this is the initial management of the airway and spiker spine. So if you cannot control the right cervical spine later with the chin lift or chakra, then later you might need to insert the airway device. Later I will show. But what I want to emphasize again is be aware of the spiker spine. So never twist and turn the spiker spine like this in the pictures. So your spiker spine must be in the straight position. Spiker spine must be in the straight position and immobilize the spiker spine in this position with the end object. Now, if you have a lot of assistant, you may as your assistant to hold with the forearm like this in the picture B. But I do not expect you might be able to do this in the like roadside current situation. There will be a short day of the medic, right? So you gotta do think of that any hard object around you there, right with the bench. So as I guess one explain. The best is there, proper is a hard spiker collar. Hard spiker collar. Okay, then what you can do. This is the oropharyngeal airway. So if you have one, you can also use this is very simple. You just insert and put inside the mouth according to the curvature of the tongue. You can put the oropharyngeal airway. This is the nasopharyngeal airway. This one also very simple to use. Just put inside the mouth, nasopharyngeal airway, and then but you can use the patient with the bleeding inside the nose, right? So sometimes bleeding inside the mouth. So you cannot use the trauma, facial trauma. You cannot use the oropharyngeal airway. Another alternative is the nasopharyngeal airway. This is not in the hospital. This is in roadside. You can try to open the secret airway like this. So for take-home message for airway, your aim is to secure the airway. Your aim is to secure the airway. So in roadside, your aim is to give the oxygenation and ventilation. So you can see that the statement, causality from hypoxia, hypercapnia, not to go because of the failure of incubation. So don't be so depressed and don't be so sad if you cannot incubate, if you do not have the facility to incubate the patients immediately at the roadside injury. So if you have a knowledge how to hold the spica spine and how to open the airway by the short thrust and the chin lift, at least some of the patient you can save before the ambulance arrive or before the next step of management you can introduce. So at least some of the patient you might be able to save just because of this knowledge, right? Because of this airway management is the very first important step in the trauma care management. Okay, next step. So next step is the breathing. So actually, most of the technique here is only if you have the facility in the hospital, you can manage that breathing. But I would like to share my experience when I was in a medical students, undergraduate medical student. So if you can open the airway already, right? So why we need to worry about the breathing? So I confused with the anatomy and physiology mechanism. Breathing is a breathing mechanism. Right? So chest wall, your neurological control. Airway is just anatomy. You are just now we discussed about the airways. You are trying to open the anatomy of the airway. Even if your airway is open, patient cannot breathe, right? The oxygen cannot go inside the lungs, right? You cannot save the patient. So because of this, next step, you already open the airway, but still patient cannot breathe. So this is useless. So second step, you have to check whether your patient is still breathing or not. Right? Vice versa is also, if your patient is not breathing, check your patient is not breathing. So don't waste your time to open the airway. So, right? So because of this, these two is actually same two sides of the same coin, right? So what you have to do is at the same time you have to check the breathing. So just I took maybe around 15 minutes to explain, but in real clinic practice, within 1 minute you should assess the airway. Then at the same time you should assess the breathing also. So in practical, the problem of the breathing is chest injury. Chest injury, you might not have the oxygen ventilator like this picture here, just to demonstrate. So chest injury, that sometimes compression on the chest. So sometimes like bone blast and breathing collapse. So in this case, a heavy object compression on the chest. Before you do anything, you have to remove this compression. This is the first thing you have to do. Sometimes there is no other injury, no internal bleeding, airway also open. Just because of the heavy object over the chest, patient cannot breathe and die. So you do not notice this. You do not notice this if you do not remove immediately, and you are just going to do the other resuscitation measure. You try to establish the IV line, right, without removing the object. So this is just a waste of the time. So because of this next step, what you have to check whether patient chest is really moving or not. Sometimes patient with a chest injury, chest wall cannot move properly. A patient with a brain injury, this is beyond our management. Patient because of the higher center control. So if the patient is chest injury, right, check patient chest wall is really moving or not. So let's see an emergency situation, what we can do. This is for, I think, medical student. So for AMO, you can already familiar with this. So I'm not going to go very detailed. right? So sign of sinuses, sign of the breathing failure, right? So you have to check the sinuses, check around the chest wall, and then focus the tunnels and listen with the US stethoscope. If there is no air entry, then despite you already opened the airway properly, still there is a sign like this. You should accept there is a you should suspect there is some airway problem. So these are the some important points. These are some important points you should understand what are the possibility of the airway failure. So tension pneumothorax, open pneumothorax, massive hemothorax, and cardiac tamponation fractures. So some of the pathology here, you might not be able to treat by yourself. Some of the situation here, like the tension pneumothorax and open pneumothorax, some hemothorax, some cardiac tamponade. If you are brave enough, you might be able to treat the patients in roadside. So these are the problem of the immediate extraordinary chest injury. After your opening of the airway, you have to look around. So these are the signs and symptoms during your physical examination you have to see. Maybe sometimes obviously there is an open chest wound. Sometimes just bruising or deformity around the chest. So you compress. Some of you might already know the chest compression test. I'm trying to compress the chest wall. So the patient complain of pain, also you will feel sometimes even crepitations around the chest because of the multiple rib stretches, but don't use too much force. So in that case, now you just suspect the possibility of the pneumothorax or tension pneumothorax and hemothorax. So if it is second one, this is very important. It is very important. So it is also treatment is also very simple. You just approach it. Dressing, just leave on one side open. Other three sides you close it back. So very quick and very simple management. So air will go in out from one side. So if you see the second one, if you see the second one, the chest, you can just use the plastic bag and maybe dressing together with the your gauze of plastic, and then you have the tape around you. Then you can see in all three sides and leave it one side open. This is very simple and repetitive immediate management for open chest wound. So tension pneumothorax, tension pneumothorax also. Here I will show the one video here. So demonstrate what is needed theracosynthesis. So you identify the second intercostal space mid-clavicular line. So in between the second ribs and third ribs. You will feel that rush of air, or sometimes you can hear the sound. You can hear the sound. If you have the facility, you can continue the proper chest strength. If you do not have the facility, just put the needle in the second intercostal space, mid-clavicular line, then transfer the patient back. This is the emergency. This is what you can do on roadside. Okay, so if you feel the patient is tension pneumothorax, so you can. This is what you can do. If you see second one, just take around 3 corners. This is what you can do in the roadside. So I'm not going to go detail about the chest tube insertion. This is you should not do, especially you have to do in emergency department. Emergency department. If it is not really challenging situation, I do not recommend. But maybe some recommend you to do chest tube insertion on the roadside. But I personally, I do not recommend to do this. So on roadside, what you can do is a needle thoracocentesis. Very simple procedure. You can save the patient life. If you have one needle, you can save the patient life. So this is the tension pneumothorax. One of the breathing problem. You can save the patient life in the emergency situation. So next step is a cardiac tamponade. So cardiac tamponade is a theory. I'm not going to go very detailed, but distended neck vein, Moffatt Hassan, right? For falling arterial blood pressure, there is a compression to the pericardium, right? So what you can do cardiac tamponade. You can do that. You can insert the needle to the right. So pointing towards the left side, and then to the right shoulder. But without the ultrasound facility, we do not recommend this. We do not recommend this. So because of this, I recommend to refer. I recommend to refer just to aware about the symptomatic sign, cardiac tamponade, some possibility of cardiac tamponade. Then I recommend you to refer. So don't do roadside. So on the roadside, you can do is check you needed to thoracocentesis and the second one. So this is the take-home message. So here you can see only 50% of chest injury require the right open interventions, chest tubes where you need. So because of this, so the rest of the 85%, you can save the patient life by your proper initial management. So don't because of this, don't worry if you do not have the proper facility or the chest tubes, or if you do not have the skill to do the chest tube position, right? So 85% of patient you can save. If you have some theoretical knowledge, that if you have some skill, sometimes you have to do your self-learning, watch the video, try yourself, right? Watch the video and try yourself, especially at that type of situation. So you cannot depend on that. Who is going to teach me, or I do not have the patience to practice, right? So you have to try yourself. Okay, so next step, AVC, is a strangulation. This one also very important. So I understand it's as far as I know. So in current situation, not because of the A and B, most of the cause of death are because of that they do not control the bleeding properly. They do not have a chance to control, or they do not know how to control the bleeding properly. Because of this, most of the patient die after 2-3 hours. Actually, if you can control the bleeding within 2 hours, right, you can save a lot of patient life in current situation. So later, if you have a chance to train the layman, you should emphasize on the circulation. Perhaps I will say A and B is for the layman, will be difficult to, right? So do the needed thoracocentesis, right? for the layman, circulation to the rest of hemorrhage, everybody can do. Everybody can do. To apply pressure, so very simple, but they do not know how to apply properly. To split the possible bleeding fracture of the long bone, this is very simple. Everybody can do. Without too much medical knowledge, everybody can do. Right. So because of this, and also most of the cause of this, rather than hypoxia, hypovolemic shock, that's hypovolemic shock. So circulation is the arrest of hemorrhages, very important in trauma care, emergency trauma care. So point pressure is a light shown in this picture. So what I understand currently is why I was in emergency in Yangon. So most of the junior doctor and nurse, they did there a lot of the cotton and bandage, and then rub. If you cannot control the bleeding, they rub again. They cannot control the bleeding, rub again. Finally, the limb is swollen, and then multiple layers of the cotton and gauze cannot control the bleeding. The key is point pressure. Even one of your finger is enough. You can imagine the radial artery position, right? Radial artery position, right? So just one finger is enough to stop the bleeding if you use properly. If your bone is a little bit bigger, like the right side picture, one hand is enough. An important thing is that adequate pressure to arrest the hemorrhage. Now what we are seeing is that they do not use the adequate pressure. They use the multiple layers of cotton and gauze. So never use the cotton. Never use the cotton. Just use the gauze or towel with the adequate pressure. Pressure is more important. Point pressure is more important than the multiple layers, right? So first, most of the bleeding in the limb, arterial bleeding, point pressure is enough. If you have an instrument, you can use the tourniquet. If you do not have, nowadays, sometimes they use the rubber ring, but it is dangerous if you cannot transfer the patients to the proper medical management place, hospital, right? So use of tourniquet is, you have to be very careful. If you cannot reach to the hospital within 1 hour or 2 hours, you cannot reach there, you cannot use the tourniquet. So tourniquet is not at the level of the injury. Tourniquet is immediately above the level of injury you have to use. So point pressure is at the point of bleeding. So I prefer the point pressure if you do not have that. If you're not sure, you can transfer the patient immediately. If you cannot transfer the patient immediately, I prefer the point pressure. So tourniquet is good, but dangerous. If you cannot use properly, it is dangerous. Sometimes you cannot adjust the pressure, use too much pressure. There will be the problem in distal circulation. Sometimes you use the tourniquet for many hours. Also, there will be the problem in the distal circulation. Right? So because of this, if you're not sure, don't use tourniquet. If you are sure you can transfer immediately, then you can use the tourniquet. Sometimes some patient with the pelvic fractures, you can use the pelvic sling. This is the proper pelvic sling. If you do not have the pelvic sling, in Myanmar, a lot of longis you have, right? So you can use your longis to sling the pelvis. So tight pressures. You can tie around the pelvic with the longis around. So at least some tamponic effects. If you suspect the patient with a pelvic fracture, you have to use the pelvic sling. So in case of the upper limb, lower limb fractures, if you have any hard object, you can splint around to mobilize. So if I have a chance to talk next sessions. I will show properly the detailed procedure of the explanation. Today is just for theoretical introductions. I cannot go very detailed. So for upper limb, lower limb, you can use your patient body as a splint. If upper limb injury, you can tie around the patient body, patient limb. For lower limb, let's say right side of femur fracture, your left side will be the splint. Your left side of the femur fracture, your right side can be the splint. You can tie together two limbs. If you have the proper hard object, you can use the proper hard object. So the key in the circulation is that if there is active bleeding, white pressure or tourniquet. If there is a pressure of internal bleeding, immobilization. This too is key in the rest of the hemorrhage. So most of the patient we lost here because of that we do not arrest the hemorrhage immediately. We do not know what to do, and then we just try and look around the patient. We lost the patient. Right? So this is the very simple procedure. Just one of your finger can save the patient life if you can use that point pressure properly. Right? So if you can do that splint properly, you can arrest the patient bleeding immediately. I remember one thing here. I just want to share my experience last time when I was in orthopedic surgeons and emergency department. Of course, I received a car accident patient. The patient is around 25, very young. Car injury, car accident, and then he was brought to emergency. I can still take the history. He can still speak. I can still take the history, and he can still speak. Even I remember he can see his vulnerable, very vulnerable. Then we did the physical examination. We do not see any injury around. Then finally we found that there is a small injury around 1 centimeter in inguinal canal. And then the bleeding is from this inguinal region. But the thing is that he was brought from there maybe 2 hour driving distance. So lots of blood lots on the way. So because of this, we examine the patient, we see the head injury, chest injury, lower limb. We do not see any fracture. So we cannot find, but that we respect the patient privacy, so we do not remove the underwear. So finally, we cannot find any injury. We remove the underwear there. The inguinal canal directly under the underwear is there. It's inguinal canal. So only blood stain on the underwear we can see. So all of the blood loss on the way, and then when the patient came, there is no trace of the blood bleeding anymore. So we lost this patient. I remember. I still see very, very sad we lost this patient just because of that. Who start to see that this patient do not have the idea to press the inguinal area, to press the femoral artery. Just one finger, you can see the patient line. So those who start to see that this patient have no idea to do the point pressures, then we lost a 25 years of patient, very young patient. I remember this. So this is the really good lesson for you. So take from other people's mistake, right? So point pressure is sometimes very important. You can see the patient line. You can see the patient. So bleeding, arrest of hemorrhage is very important. Bleeding in emergency situation. So the rest, disability, I'm not going to go very detailed. So some other lecturer also, they will say GCS, right? So but generally, whether patient is alert or not, responses or not, this is the general assessment of the patient neurological status. You also should do in emergency to categorize the patient as red or green or yellow. exposures. This is the one I want to say. So remove all the patients just because of that. We don't expose the patients underwear, then we lost the patient, we delay the resuscitations, and we lost the patient. So, but one of the cause of death in the emergency situation is a hypothermia. So because of this, you should not expose patients in very cold weather. I think lucky that mainly it's very hot, so there will be then no issues. But it is an emergency room with the aircon. You also have to be very careful about this. So you have to examine the patient front and back and then don't roll carefully. So this is the thing you have to do. This is the thing you have to do in exposure. The key is there. We have to respect the patient privacy, but do not hesitate during your physical examination to expose all. So if you're reluctant to expose all, you might miss the important life-threatening injury. So this will be a problem for you in the resuscitation. So secondary service, after primary survey, you have to continue there to do secondary service. Today, I'm not going to discuss the secondary service. Today is a scope of our discussion is emergency situations only. This is still emergency, but after primary management, you have to do the secondary service again. So today I want to focus on primary service again, just to get the idea. Primary service is not enough. Primary service is not enough. You have to do the secondary service again. So this is just example of lock rolling. If you are going to turn the patient, right? So at least you need 2-3 student assistants then hold the spiker spine with the spiker collar properly and turn in the lock roll. Sometimes, most of the cases, you lost because of that. You do not carry the patient properly. You do not turn the patient properly. Initial injury is there. After our physical examination, there is a secondary damage. This is also one of the problems. So because of this emergency, right? If you want to do physical examination, hold the patient properly like this. This is we call trauma lock patients. Because some of the those who already in emergency department, already work in emergency department, they might know very well about this. So this is the timing you have to. So let's say the one who holding the spiker spine is a leading trauma leader. So she has to give the timing 1, 2, 3, and then to the right side. You have to give the clear explanation which side you are going to turn. Okay, right? So you are going to turn the right side. Other assistant is going to turn the left side. You will twist the patient spiker spine and then finish. Right. So as a trauma leader, you have to explain clearly and then count the timing. 1, 2, 3, 10. Turn the patient to left side or right side. So then you examine the patient back, then the whole body clear. So this is the lock roll method. So there are so many steps in the secondary service. For today, I'm not going to discuss very detailed. So hopefully, you might have some benefits. Some of you may be new, some of you for revisions. At least some of you have some idea that at least you believe that one of your fingers can save your life without any instrument. So I'm happy to, if you have any questions, I'm happy to answer. So because of the situation, I know you cannot communicate with me, you do not want to communicate with me, it's all right, no problem. So if you have any assistance later on from the organizer, I'm happy to help you in any way. So thank you so much, and then today discussion I will close here.